Hello everyone and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would like to now turn the meeting over to your moderator, Haley Warren, Improvement Lead at CFHI. Please go ahead.
Hello and welcome to today's webinar entitled How to Engage and Support Diverse Patient Partnerships During a Crisis. My name is Haley Warren and I will be moderating this session today with my lovely co-host Justina Marianigam. This is part one of a two-part webinar that will unpack a variety of considerations for engagement with diverse patient populations. We will explore the added challenges brought about by COVID-19 and specific ways we can do better now and after the pandemic. Thank you all for taking a moment to fill out our lobby poll. It's so interesting to see how many of you are coming from an organization or engaged with an organization that does have a current strategy to consider equity and engagement with diverse patient partnerships and how to support these partnerships. During our webinar, we will be learning from folks who work in this space and who are working to unpack how COVID-19 has created or exacerbated challenges in supporting these partnerships. And we will be very interested to hear from all of you about what has changed in your organizations. Thank you for joining us from wherever you are across this country. I can imagine for most of us, our places of work may look very different than they did a few weeks or months ago. I am joining with you all today from my home office in the Greater Toronto Area on the traditional territory of the Mississaugas of Scugog Island First Nation, where I am so fortunate to work, live, and play right by the shores of Lake Ontario. And a shout out to the CFHI broadcast team who are working from their home offices as well, which are located on the traditional and unceded territory of the Algonquin Nation. This is also where the CFHI office is located. We are pleased to be offering this discussion series, including today's webinar, bilingually. The telephone number to connect to the French audio can be found on the screen, and we invite you to use either official language when entering your questions and comments in the chat box. As a reminder, we are also recording this session, which will be archived on our website. You'll be able to find that within the week. The main purpose of these discussions is really for us all to share and to learn together, having a place to discuss relevant and topical issues of patient and family engagement during this evolving pandemic, and to be able to include and welcome multiple perspectives of those involved in patient engagement across Canada, those working within organizations and healthcare systems, and patient partners who have been involved in health system improvement, to gain insights into innovative engagement practices as well as where challenges remain. For those of you who have joined us before, you will know that the chat box is the prime mode of conversation and that these chat boxes do move quickly. We will do our best to raise comments from the chat box throughout today's session, but please be assured that we do capture all of the comments in the chat box, and we will provide a summary of the conversation that will be shared on our website in the following week. As noted earlier, these discussion sessions are recorded, and the link will be available for you to listen and view again if you would like. What we share helps us all to better understand the rapidly changing landscape of patient engagement across the country during this time of pandemic, and importantly to consider ways that we might strengthen engagement and partnership and respond to emerging challenges. During today's webinar, we hope participants will have the opportunity to learn from two organizations about how they have been engaging and supporting diverse patient partnerships during the time of COVID-19, really generate discussion to continue to consider equity and how to engage and support diverse patient partnerships in a post-pandemic world and during crises, and to examine strategies that folks can bring to their own organizations and engagement work and within their own lives to engage with and to support diverse patient partnerships. Now it is my pleasure to introduce Justina Marianigam, a patient partner and medical student. Justina is a Canadian medical student and has lived and living experience with chronic pain. Originally from Yellowknife, Northwest Territories, Justina has been a noteworthy advocate for children living with pain. As a pediatric and now young adult patient navigating the healthcare system, she has recognized inequities that existed and has been working to drive solutions to help others through advocacy. Nationally, Justina was appointed by Health Canada to the Canadian Pain Task Force to help address chronic pain for all Canadians. She liaises with northern communities to improve rural and remote engagement based on her personal experience as a patient in the subarctic. She's also a board member for Solutions for Kids in Pain and is working as a patient partner to improve knowledge translation by bringing evidence-based pediatric pain research to practice. Provincially, Justina is an advisor to the Ontario Ministry of Health, focusing on transitions from pediatric to adult pain care. Locally, she mentors young patients and designed and launched the first pediatric patient-to-patient chronic pain support group in Canada. Internationally, she is representing the patient voice as a consultant for the World Health Organization to develop the new guideline to management of pediatric chronic pain. Justina is taking her lived experience with chronic pain and working towards completing her MD to become a physician specialized in this field. Welcome, Justina, and over to you.
Hi everyone, can you hear me? Yeah.
Sound great.
It's always embarrassing when someone's reading off your CV in front of everybody, but it's really great to be hosting this webinar today and be able to connect with you all. As mentioned, I'm connecting from Yellowknife, my hometown in the Northwest Territories, so situated on the traditional land of Yellowknife, Dene, First Nations, and North Slave Métis. So grateful to be able to broadcast, and grateful that my northern internet is being able to host a video right now. So as Haley had mentioned, I'm currently I was a pediatric chronic pain and rheumatology patient, now a young adult patient, still navigating within the rheumatology and chronic pain world, and I'm here to kind of host and moderate patient partnership. Specifically within in focusing on diversity, especially during COVID. So when COVID hit, I came back to Yellowknife, my rural hometown, to work for the government, because I strongly believe that the rural remote perspective and working in healthcare is really important, especially as someone, my family immigrated to the Arctic when they first came to Canada in the 70s. So just again, really want to hone in on like importance of diversity and engaging with patient partners in rural remote communities, and especially within our immigrant population. So excited to host today. Thank you for having me, and I'm really looking forward to today's discussion.
Thank you, Justina. It is our pleasure to host you as co-host, and lots of folks in the chat saying no need to be embarrassed, you do so much, and really looking forward to your perspectives of rural and remote engagement and what's going on in the subarctic at this time. So I am now very happy to introduce our first presenters from the Scarborough Health Network, Christy McDonnell and Lori Berger-Hedgie. Christy is the Manager, Health Equity, Patient and Community Engagement at Scarborough Health Network. She is a passionate healthcare leader and adjunct lecturer in the Faculty of Social Work, University of Toronto, who is committed to partnering with families, interprofessional teams, and the community to design a healthcare system that truly delivers quality care to all. Through authentic partnerships, she strongly believes we can improve access to comprehensive quality health services and achieve health equity for marginalized populations. Lori has been a patient family advisor for Scarborough Health Network since 2016. Her initial participation was on the nephrology PFAC as she provided home hemodialysis for her husband. After his death in 2017, Lori found that participation in the areas that she had experience in allowed her to heal by looking outward, honoring his memory, and giving back to the hospital that cared for him so well. Thank you, and over to you, Christy and Lori.
Wonderful. Thank you so much, Haley. It's our absolute pleasure to be with you here today, sharing a little bit about what Scarborough Health Network is doing during this time of COVID. I just want to do a quick sound check. Can everybody hear me?
Sound great.
Oh, perfect. Okay. I currently have a black screen, but as long as all of you are good to go, I will keep going. As you'll see from our presentation, there are a variety of different slides, but I'm going to really focus on these slides that have a turquoise accent on it. And about a year ago, we had the opportunity to launch a health equity certificate program that actually partnered with community leaders as well as patient family advisors and community advocates to really think about the social determinants of health. So really thinking about how does housing or education opportunities impact one's health outcome. And when COVID struck in March, April, we decided to tweak or pivot, as the word is these days, some of the course curriculum to include discussions around mental health and vulnerable populations and how it impacts very particular groups of people. For example, children. So what happens when children no longer have the school system to support them, particularly coming from a vulnerable population or a vulnerable household? For example, their teacher may be one of the most positive or influential people in their lives. They may benefit from things like food security, breakfast clubs, lunch clubs, or after-school programming. And when that's taken away, there can be significant impact on the family unit, and particularly the child. So we have begun to focus our attention really thinking about child and child development during COVID, as well as the refugee and new immigrant experience, as well as those living with low income and essential workers. And what we find is that for a lot of time, some of the mitigating factors that many of us have benefited from aren't the same for vulnerable populations. So when we think about, for example, I think everybody that has sort of come onto the chat line has talked about how they're working from their home office. And for many, working from a home office isn't an opportunity that they have, or reducing, transportation, public transportation, still needing to resort on that, whereas for many of us, we've, been able to reduce that or drive in our own cars. Thinking about overcrowding, Scarborough, Ontario, the hospital in which Lori and I both are part of, when we think about overcrowding in homes and how that can expose you to COVID. And so it's been a really, really great opportunity to encourage dialogue with our Health Equity Certificate Program participants, which is approximately 90 people. We've done breakout groups, which Lori has been a part of, and like I've spoken about in today's sort of key messages around how we're continuing to partner with patients and families and how we bring in diversity and inclusion. Well, that is in very fact how we do that with this program, is that we have opened the session to allow for patients and families and clients that represent different services in Scarborough to be a part of this program, Lori being one of them. And when we do break-off groups, such as the ones that we've done during the COVID period, it allows for those individuals to bring their lived experience to the discussion, which is really, really important. I'm now going to flip it over to Lori, and Lori's going to share her perspective in being a part of the Health Equity Certificate Program.
So as a layperson, not having a healthcare background, the Health Equity Certificate Program really opened my eyes to the differences in society, including the social determinants of health, and how they affect the quality of life and the health of people in my community. Scarborough certainly has a large immigrant population. Christy mentioned, or there were slides that mentioned some of the numbers. So my experience with it, from a privileged perspective, my experience with disability, mental health, dementia, frailty, and having a loved one in long-term care has positioned me to greater appreciate the challenges that the residents of Scarborough, of which I am one, and most of my family are one, and how I can affect positive change and influence things with a wider lens than I had before. Some of the challenges to the continued engagement with PFAs, of course, now is not in person, so there's technology, and the hospital has certainly used that to a great extent in terms of Zoom meetings, breakout rooms, survey monkeys. We actually, the Patient and Family Advisory Council, we do a social once a month, just us, to sort of chit-chat and talk about how we're coping and our family issues, things like that are happening now in the crisis of COVID-19.
Great, thank you. So that concludes our very quick presentation for you today. If you have that we're very proud of at Scarborough Health Network. And so if anybody's interested in any additional information, please feel free to connect with us, as this is really just a very small sort of snapshot into what we're doing around COVID. Thanks very much.
Thanks, Christy and Lori. I think we have a question from Justina just about the wonderful work that you're doing. Oh, I think you're muted, Justina.
I think someone needs to unmute me.
We can hear you.
Hear you now.
Okay, I think someone needed to unmute me, someone higher up in the tech sphere here. Yeah, I had a question regarding recruitment, because I think there's, from my experience, like engaging with patient partners, every time I say, okay, we need to engage with more people from like vulnerable populations or like in rural remote communities, and then the feedback from people in leadership are like, well, how do we find them? Or like, how do we get in contact with them? How do we recruit them? Or we get into a situation where we find one person that fits, one or two people who fit the category, and then we kind of only go to them. So what are some strategies that you have for recruitment?
Yeah, sure. Thanks for that question. We actually just presented at the International Conference on Patient Experience Barrel Institute on why recruiting for diversity in your patient family advisors is critical. So I'd be happy to share that presentation with you. But very briefly, one of the things that we did with our aim to include a very diverse patient family advisory group of people is we made sure that we were creating a system that was going to be inclusive. And I'm going to give just a couple of examples. One of the things that we do at our council and in all of our engagement is we make sure that our spaces are accessible for everybody. So we make sure that the rooms and the meeting spaces that we're meeting in are inviting. As an example, one of our hospitals, it doesn't really fit that bill. There's many, many stairs. And so in order for somebody who may have some mobility concerns, it'd be very challenging. Therefore, we just don't use that facility. Another thing that we use is inclusive language. So making sure that we're, using language like folks, making sure that people feel welcome. One of the major things that we do, and Lori spoke to it, is the use of breakout rooms. We are very, very lucky. If I use our Patient Family Advisory Council, it's very intentional that I have 5 staff that work that council with me each month to allow for World Cafe style interaction. We always, or most often, break into groups where there can be a small group discussion where it's led with a facilitator to allow for everybody to have a good understanding of the engagement activity at task and to allow for individuals to feel that they can have a voice in a smaller setting. The last thing that we have is that our patient family advisors don't compete to be a part of our council. We simply add more chairs. So I know for a lot of key facts across the country, you may have 10 or 12 members. Ours, we have patient family advisors, we have 60, and as many as 60 are welcome to join. So those are just a few of the things. We also work with a lot of our community partners where we specifically go to shelters, food banks, etc., encouraging their staff to have a good opportunity to encourage participation of patient family advisors.
If I could just add, Justina, I'm with the OHTs, the Ontario Health Teams, which are being created. They're sort of on hold right now. There are absolutely, I'm a co-chair of one of the committees for patient and client engagement, and we're going out to our community partners at every opportunity asking for their nominating people who can contribute in a meaningful way.
That's great. Thank you so much for really highlighting that. And I'm looking in the chat, and people are all in agreement, and other people are interested in hearing about the presentation that you mentioned, Christy. So I'll put it back to Haley.
Yeah, absolutely. And certainly, Christy, if you're willing to share your work, we can absolutely circulate that presentation with the recording in the archive and the supporting materials from today's webinar. We did have one other question from Ioana that I will ask before we'll move on to our next wonderful speaker. And keep your questions coming in the chat. We can bring them back when we come to our question and discussion period. But Ioana was just wondering if there is any evidence on safety in relation to equity that you might have at your organization.
Sorry, I have a little toddler who just decided to pop in. Can I get that question again, please?
No problem. As we were saying, the very big differences of now working at home and our new realities. So just a question from Ioana, wondering if there is any evidence at your organization or you have any evidence on safety in relation to equity.
Yeah, and are you meaning in terms of from a cultural point of view or a sensitivity point of view in terms of some of the policies that we might have? Or
yeah, I think safety can mean a few different things when we think of cultural safety or safety actually at the bedside at the point of care. So any thoughts on any elements of safety I think would be much appreciated.
Yeah, well, we do ensure that our patient family advisors are appropriately trained and have an understanding of their role and the parameters of their role to ensure that there's sort of physical safety, as well as we do training around, from a psychological point of view around safety, ensuring that our patient family advisors are only sharing what they're most comfortable sharing. And of course, that might change depending on the group in which or the audience that they're sharing with today. As an example, for Lori, she shared a little bit about her personal experience, and I know that in time she shares a lot more details, but we train our patient family advisors to do that in a way that they feel most comfortable. I'm not sure if I'm hitting the mark on that question. I don't know, Lori, if you have anything else to add.
When I think of safety, I think more of the physical safety, and certainly within the hospital walls, everything is as safe as it possibly can be.
Thanks, both. Lots more questions coming in and comments about the work that you are doing. I have them all noted, but we will put a pause on them, and we will move over to our next speaker. So again, thank you so much, Christy and Lori, for sharing about all of the wonderful work you're doing and have done, and the shift that you've made to continue to engage during COVID-19. I will now hand it over to Faria Khan, one of our other amazing presenters from Alberta Health Services. Faria has been working with Alberta Health Services for a little over 6 years. She completed her Master's in Public Health, specializing in Global Health and Diplomacy from the University of Saskatchewan. Her current role with Alberta Health Services is as a provincial initiatives consultant working in addiction and mental health with a focus on youth. She is currently involved in several provincial and national projects to address the ongoing opioid crisis impacting youth and young adults. Over to you, Faria.
Great, thank you so much. Can everyone hear me? Can I get a quick thumbs up? Perfect. Okay, thanks so much for the introduction. So again, my name is Faria, and yeah, my work is predominantly with youth, and as Christy had mentioned, it's so important to look at youth, especially now with COVID, as you know, youth are being really negatively impacted by the pandemic. There's a lot of disruptions in their life when it comes to school, the ability to graduate, and going to college, and even getting jobs. So it's really important that we continue to keep them engaged during this time. So I do work in provincial addiction and mental health, and my area is called SciFi. So I have a lot of acronyms here on this slide, but I work for Child, Youth, and Family Initiatives. And so within my portfolio and the work that I do, we have a tri-party agreement. So it's Alberta Health Services, and we have two of our partners, so we have CCSA and CRISM. So they're both national organizations that look at substance use and addiction. And so I've been fortunate enough to work on these three different areas. So the first is YAMPAC, which is our Youth Advisory Council. So we have youth from the ages of 12 to 26 that we come together and we have meetings and consultations with them to discuss topics around mental health and addiction. So this council has actually existed for exactly 1 year now. It was founded back 1 year ago in July, and we've hosted 4 meetings so far, and we actually just had one last week, which I'll talk about a little bit later in some of my upcoming slides. But basically it was founded to provide youth with that voice to talk about their lived and living experience around mental health and addiction. The second point here is ITT projects. It's the Improving Treatment Together project. It's the bulk of my work that I do, and we're working with youth that have lived or living experience around opioid use. And the purpose around this project is to actually create resources for youth, for family members, and for service providers so that we can improve accessibility and utilization of treatment services around opioid use. So we're actually in our next phase of the project, which is creating the resources, and we're working closely with youth, who we call youth champions, and they're working closely with us to develop these resources and ensure that there is that youth perspective as we develop. And lastly, CRISM is another organization that I'm doing research with, and so we're looking now more at siblings and family members of young people that have experienced harms related to opioids. So you can go to the next slide, please. Perfect. So now I just want to talk about some of the events that we've been able to host during COVID. And obviously the success of these events are due to our relationships that we've built with youth through our council and through the ITT project. So with the ITT project, we were actually able to host one workshop virtually. And so with the project, we did about 7 workshops all across Alberta in person. So having that in-person engagement, really interactive, to really hear firsthand from youth what their experiences are as they use different treatment services around opioid use. Unfortunately, due to COVID, we had to switch and transition to a virtual workshop. So with that came a lot of, changing and adapting to our workshop, like shortening the hours. We had 5-hour-long workshops in person, but obviously online we had to switch it to 2. So just making it really adaptable and something that could still be very productive and meaningful, that's what we were able to do with our workshops. We also have ongoing work with our youth content working group. So like I mentioned, we're creating resources right now, and we actually have a group of youth from our council as well as from our workshops that were done in Grand Prairie, and so we host meetings every week, and we're continuing to get that voice from the youth and get their input as we develop resources. Over onto the second part of the slide, so YAMPAC, that's our Youth Advisory Council. We were able to host consultations with them during COVID, so this was hosted in April, and we hosted consultations to discuss the impacts of COVID on substance use as well as on mental health, and just get that the feedback from our youth on what their experiences are with COVID. And so it was really nice because we had some great outcomes from the consultation. So it was hosted with our partner CCSA, and they're actually working on 2 campaigns, youth engagement campaigns, and we were also able to host an educational webinar for youth allies. So that would include parents, teachers, as well as service providers. We also hosted a quarterly council meeting, so this was done over Zoom, and it was about a week ago actually. It was our 4th meeting with our council members. We had 20 attendees, so it was a great turnout. We had great consultations and really amazing discussions. And finally, we also have ongoing work with a subgroup of our YAMPAC counselors, and so they come together and they're working on marketing for the council. So we have a lot of work that's still going on even during COVID. Next slide, please. So now I just want to talk about how to keep youth engaged. This list could definitely go on for a few slides, but I tried to condense it as much as I could. But it's really important to keep these things as take-home messages. So the first is talk about things that are relevant to them. It's so important to keep them engaged, to talk about things that they can relate to, things that they've experienced, and it's important as us as staff to really acknowledge their lived and living experience. We like to call them subject experts whenever we work with them, whenever we host any event or meeting. So again, to keep them really engaged, it's about talking about things that they want to talk about. Secondly, building a trusting relationship with the youth. This obviously takes time, but we definitely have tried to build that relationship with the youth whenever we host any event, whether it's in person or online. We really try to build that rapport with them, try to, build that relationship, ask them about how their day went, how their weekend went, just kind of have that exchange. You can also share something personal about your life just so that you can really build that relationship. And as Christy mentioned, using language that they can understand, not using high-level language or clinical terms, things like that. You really want to use the language that they will be able to understand. We have council members as young as 12. So it's really important to be very flexible in how you speak and address them. That goes to my next point, being flexible and accommodating, especially during COVID. Oh, sorry, thank you. So with COVID, understanding that we can't do in-person engagement anymore, so being flexible as to how you're going to continue on with your events. We didn't want to stop our project, especially with the ITT project. We continued on with the workshop. So ensuring that, you can be flexible and accommodating. We were able to host our workshop successfully because we had one of our community partners actually lend laptops to some of our youth that didn't have laptops at home and provide them that safe space so that they could engage in our consultation and workshops. And just really meeting the youth where they're at, because, you know, with youth that have mental health or addiction issues, you know, it's going to be really up and down with them. So being flexible and understanding that, you know, some days they might not feel like engaging in meetings, some days they might be. So being flexible around there. My fourth point is to allow youth to take the lead. You want to empower them, get them to do work. And whenever we have meetings, we always have youth, you know, engaging and facilitating some of our discussions. So giving them roles is really important as well, because they feel like they're sitting at the decision-making table. And then lastly, during COVID, obviously, you know, that transition to Zoom and all these online platforms, it's really important to use that, but also use it in a way that it keeps things interesting for you. You don't want them falling asleep during consultations. You want to ensure that you have breaks. You want to ensure that you're really interactive using polls or the whiteboard or the chat box. Those little things really, they add up. Next slide, please. Thank you. So this is my last slide. So just a few lessons learned. Again, I think some things were kind of mentioned by Christy and Lori earlier, but creating that safe space is so, so important. These youth are vulnerable. They're sharing very personal things. You want to ensure that you're creating a safe space for them, making sure that there's a lot of respect and no judgment, either from staff or from other youth that are involved with these engagement pieces. And again, protecting their confidentiality, reassuring them that their names or anything that could be identified to them will not be, you know, used or mentioned outside of our meeting. So creating that safe space. Thirdly, you want to find the best way to communicate to youth. It's very different with youth. They don't reply to emails as many. You can send as many emails as you like, but it's just very different with them. So finding the best way to communicate. For me, I found with my youth that I work with, texting is the best way. So they appreciate that and they respond right away. So just being very, I guess, open and flexible to how you communicate with youth. Another thing is the positive reinforcement goes a really long way. You want to really make sure that your youth feel valued when they're sharing their experiences. You want to also show the outcome of their work. For example, we had a youth summit, and from there we actually had one youth present information from that summit at a conference in Vienna. So it was just really nice to see that our conversations in Calgary, Alberta went all the way to Vienna in front of the UN. So showing them the outcome of their involvement is also really reinforcing. And finally, just being open and transparent with the youth, you know, defining roles, also defining expectations of what can and can't be done, and just really outlining the scope of the work that you do. So thank you so much for listening to me. I hope this was helpful and informative. I'll turn it back to Haley.
Thank you so much, Faria. Lots of great comments about your work in the chat box, and lots of questions as well, and some questions from earlier that I think Justina and I want to bring back around to address before we move on to our formal discussion and question period. So I'll hand it over to Justina first to ask a few questions from the chat box and that she had herself. So go ahead, Justina.
Yeah, sure. Thanks for your presentation. I was really interested as like a former youth. I still don't know if I'm still considered a youth in my 20s. I don't know what the cutoff is for being young. But I had a question regarding your shift with your patient partnership by being virtual. I think there's maybe a bit of a misconception thinking that like all younger people are good with technology or used to it or like it better than in person. I can't imagine having to shift from being a patient to doing everything virtual when all my care was in person as someone who was younger, and how it's difficult even for young people to open up to clinicians and open up to parents and stuff like that. So I'm curious, as a group, as your youth patient partnership, have you talked to them about future directions of like even in this post-pandemic world? Do they think they prefer virtual? Do they prefer in person? Do they like the hybrid of both? what is their take on future directions? Because personally, I started a new medication with my physician virtually, and again, it was very difficult to navigate that virtual care versus in person. So that was my first part. And then the second part to my question is addressing what Robert Barnett has said in the chat, coming from Laurentian, and again, highlighting this urban and rural perspective. How are you working at AHS to increase, making sure there's representation of your entire catchment area that goes beyond just, Edmonton, Calgary, the urban centers, and reaches out to like Grand Prairie or I'm even thinking in Yellowknife, because you guys are the feeder hospital for us from the territories.
Yeah, for sure. No, thank you for those questions. So with the first part, so it has been a challenge shifting over to Zoom, or we use like Skype and all these different things, but I think just being really patient with the youth and giving them options. So not all of them feel comfortable showing their face on webcam. So if we do host things over Zoom, we give them the option, like you don't need to show your face. You don't even need to speak if you don't feel comfortable. And we've noticed that the youth really love the chat box. I feel like, and even like us as well, I feel like everyone you can feel a little bit more free and less vulnerable when you're using the chat box. So giving them those options. We also give them the option if you want to call in as well if they don't have a computer. A lot of youth don't have working internet or smartphones and things like that. So just giving them whatever options we can, and also realizing that engagement isn't going to be their main priority right now, especially during times of COVID. So, giving them that space as well and the option that you can engage in these things if you like. If not, it's totally up to them. So again, it's going back to meeting them where they're at. Secondly, you asked about, rural and urban, and so with our council, actually, it's not just Calgary youth. We have youth from all over Alberta, so we do have people from more rural areas and urban. We have Grand Prairie. We're trying to focus on all zones. Our recruitment, we have a recruitment strategy, and so we want youth from different zones. So we have Central, which is Calgary and Edmonton, and then we have South, which is like Lethbridge, and then North, which is Grand Prairie. We also make sure that we have diversity within our council. So we have youth that are of Indigenous background, we have visible minorities, we have LGBTQ. So we try to ensure that there is a lot of diversity, and we've tried to, advocate, and that's kind of one of our projects that we're working with the youth is the recruitment flyer, and we're trying to ensure that everyone can feel comfortable enough to join the council regardless of their background, because I guess in essence they have that one thing that really connects them together, and that's addressing mental health and addiction. So I hope that answers your question.
Yeah, that's amazing. Congratulations on everything you're doing. It seems like you're taking the right steps, and I'm really glad we're engaging with as much as we can. There's never a perfect engagement strategy, but I can tell your team's doing your best. I know Haley now is going to sum a few other questions in the chat.
Yeah. Thanks, Justina, and thank you, Faria. So, Faria, there was a question about how to ensure that youth had access to technology that would allow them to attend the virtual workshop, and I do believe you answered that by sharing that you did go through a process of loaning laptops, and I would also ask that question of Christy and Lori as well about how in a more general way beyond youth, how you're ensuring or checking in on access to technology. And that also ties into a question from Kristen Hemming, a question for anyone or any of today's presenters. In a world of COVID, we're looking to do more of our engagement online with our patient and family advisors, but also with other clients, residents, and patients outside of a dedicated advisory council. With that, we know that some of the groups of participants may not have had access to internet or technology that can connect them in as many public access sites are closed. I'm wondering what your thoughts and ideas are on ensuring we're reaching our systematically oppressed or diverse participants in our new normal when there's a lot of work going online. So Faria, I would wonder if you have anything else to add about ensuring access to technology before going over to Christy and Lori to hear from them about that piece.
No, for sure. So yeah, like I mentioned, we work with community partners for our ITT project, and so the youth that we were working with, they specifically, had opioid use disorders. So the youth that were involved in our workshops were still actually going to the clinic during COVID because they need to get their treatment. It's an IOT treatment that's done daily. And so they were still attending the clinic, obviously using safe social distancing practices. So by them attending and being there, our partners who were clinicians, they were the ones that were able to provide the laptop and all that kind of stuff at the clinic itself. With that being said, it's still, a lot of youth still fall through the cracks, the youth that don't continue on with their treatments or that don't get to go to counseling, things like that, in person. It's still really hard. And so, yeah, I'm curious to see what, if Christy or Lori, if you have any other ways that you guys have engaged youth that don't have access.
Yeah, thanks for that question. It's really, really important, and I think it's a question that we will continue to work with. And I think that depending on your situation, you may have very limited access. And currently, the group of patient family advisors that we work with today have either access to a computer. We do a lot of our communication now or activities over Zoom. It also allows for there to be a call-in. And we know that the majority or all of our patient family advisors do have a telephone or access to a phone, and some of them have been able to participate that way. So they don't get the opportunity to see what's happening on the screen, but we make sure that we send out all of our materials in advance to allow for that person to have it. That being said, it's not a perfect solution. I do have a few tablets that I can share with those that want to participate but may not have that piece of technology that they require. Again, the challenge is that they would need then to find access to internet. So my guess is that if they don't have a computer, they probably don't have Wi-Fi capabilities. They aren't able to go to a library or things like that. So again, it's a challenge. I have to say a lot of my engagement continues to be over the telephone. It's not uncommon for me to give a group of people a call, put them on speakerphone, and have sort of 5 of us speak at a time. Interesting from a clinical point of view, during COVID, my role, I was seconded to help the hospital virtual care capability and digital health. And what is really, really interesting is that now 3 months in, when we evaluate our community and our community's interest in virtual care being delivered to them, it's high, but it's actually over the telephone. So though we have OTN, or Ontario Telemedicine, or Zoom Healthcare, or MS Teams, et cetera, to be able to interact with our community in a healthcare way, most would prefer that you actually just give them a call. And a lot of our physicians actually just prefer picking up the phone and giving their patients a call. So I guess you can never undermine basic technology. And as we quickly move forward with advancing technology, sometimes it's important just to keep it simple.
To echo that, Christy, my professional hat is as an office manager of a primary care office. And in this time of COVID, we're doing probably 97% by telephone. So,
interesting.
Yeah, and I think people are quite comfortable. We have introduced using email for visuals of some things, and then if absolutely necessary, the physicians can bring the patient in.
Mm-hmm.
Thanks. There is a comment that I think ties in very well to this chat about technology and access from Lisa, just about from my experience, some of the youth and families we support have commented that the virtual options are very limiting for them because of poor internet, and so they are feeling more isolated than before. I think we need to find multiple platforms to support a wide range of diverse needs. Totally agree, Lisa. I think there is definitely a need for more platforms to be added to the engagement space so that we're reaching more folks. I am going to move us on to one other question that has come up a few times in the chat box before we go to our formal discussion questions. And Christy, I do believe you addressed this question about compensation, but it's come up a few times, and particular questions, Faria, about compensation for youth and whether that's something that is done in your program and whether that is something that you do or how you might do it. So just wondering if you have any thoughts on that and what compensation does or doesn't look like within your program.
For sure. So I know I saw in the chat box it came up quite a bit. So for the youth advisors, the council members, we don't directly, we don't compensate them for attending the meetings. However, we do an onboarding process, and so they are formally known as AHS volunteers. I know that's not an honorarium, but it's still, I think it still speaks volumes because it's something that you can put on your resume. And for a lot of these youth, they really rely on that, especially because a lot of them are young students, applying to university. With our other partners, though, with CCSA and with CRISM, we do provide honorariums. So whenever they participate for any of our workshops, any of our consultations, they are provided, they're provided an honorarium, and we've also we've flown them in. So if they're from different parts of Alberta and we're hosting something in Calgary, we do provide accommodation and everything so that they can come. And for our first advisory council meeting, actually, we did get funded from CRISM, so we were able to host our first meeting in person. And so we had youth come in from all different areas, and they came in for that. Another thing that I want to mention with our content working group, so we have ongoing work that's going on with our ITT project, so in development with the resources. We are providing compensation for the time that the youth put in, so we call them youth champions. And yes, they are getting paid for every hour that they put in, whether it's for meetings, whether it's for reading meeting minutes, things like that. And that was kind of one of our ways of addressing, just the job loss situation during COVID. We have a lot of youth that said, hey, I'm just sitting around, I'm not doing anything, I don't have school, I lost my job. And so this was some of the ways that we try to, give them something to work towards, keep them busy, keep them engaged. And luckily with CCSA's funding and help, we were able to provide them honorarium for their work. So definitely it is important to provide that. It's a great incentive, and I mean, none of the youth ever expect it, but it's just nice that we're able to show how we value their time and their input. It's a great question.
Thanks, Faria. Cognizant of time, and we do have some formal discussion questions we want to get to, but I do see a comment from Tracy in the chat sharing about their compensation processes, that they do provide financial compensation for advisors at approximately $20 an hour as maximum, and with maximums, and in Saskatoon they do provide the youth with cash. And lots of chat about how we are recognizing youth patient partnerships and what the meaning of the work is with youth patients. Okay, let's move on to our first discussion question. So again, thank you all so much for sharing your wonderful work with us, and for all of you for participating in the chat so far. Please continue to chat your comments and your questions into the chat box. So as we mentioned earlier, our chat box does move quite fast. We will do our best to get to all of your questions, but if we don't, we will share your questions with the presenters afterwards, as well as the questions that were posed earlier in the conversation. So, right now we know that patient engagement efforts do not always reflect the range of patient populations that need or use healthcare in Canada. What do you anticipate the future of equity and engagement in a post-pandemic world to look like? And what have you put in place to ensure the continuation of your programming and efforts? Maybe we'll go to Christy and Lori first.
Sure. Thanks for that question. That's a great one. Very thought-provoking. I reflect on our Health Equity Certificate program and how we were able to shift and really think about COVID and how COVID has impacted the most vulnerable and the most marginalized. And I think COVID exposing the vulnerability that exists to such a degree. I don't know if many of you know Dr. Kwame McKenzie. He works at CAMH, as well as he's the CEO of the Wellesley Institute. He's written fabulous papers on what he expects the new normal to be, really focusing on homelessness. And we are representing Scarborough, and of course Scarborough is part of the greater GTA, and the impact that COVID has had on the homeless and reducing shelter and shelter spaces, etc., is extremely devastating. And I think it's a lived experience like this that will help to ensure that equity and our drive towards health equity continues to be on the agenda, continues to be a high priority for our organization. It currently stands as one of our strategic directions to improve population health in Scarborough over the next 5 years. And I think one of the silver linings coming out of COVID, again, is going to be to really ensure that we look at our health equity strategy and ensure that it truly is leveraging and helping the most vulnerable to rise. I don't know, Lori, if you have any additional comments.
I think from my perspective, the Health Equity Certificate program has certainly opened my eyes. So I'm looking, I think I said this before, I'm bringing a different lens to everything that I participate in, and ensuring that I'm including everybody as opposed to my small, whether it's my demographic, where I live, my language, my health status. So I think it's, I'll certainly continue, and I think there's maybe half a dozen PFAs in the program, Christy. Is that correct? Maybe 10. And so I'm hoping that we can all bring that back as we participate in more to do with the hospitals.
Thanks, both. Faria, any thoughts on that question or anything to share?
Yeah, no, I think, yeah, thank you, Christy and Laura. You brought up really good points. And I think, with COVID, so many organizations and companies, we've shifted to this virtual world, and it seems like this is going to be our new reality. And so I'm anticipating for the future that these applications like Zoom, that we have more options, that they're more refined, and they allow for more security and privacy protection, especially when we're talking to vulnerable populations. I think also it's important to take note of just the social and psychological impacts of living in a post-pandemic world. So, we hope to identify and study those impacts and, find solutions to them and see how can we include that in our mental health programming. One thing that we've started to do is we have psychosocial support present at our meetings, even over Zoom. So we have an addiction and mental health counselor that comes to our meetings, and we always, refer to that person, and we let the youth know that if at any moment they need to talk to someone, they have that option. And we also had this counselor call each of our youth individually after our meeting just to check in with everyone and let them know that, again, she's available if they need to talk. So obviously that is time consuming, but we're just hoping that these tweaks and these things that we do, especially during COVID, that we're able to provide those supports as much as we can. So.
Thanks, Faria, and really interesting and great to hear the ways that you've built in psychosocial supports, and I think we can't underscore the impact that will be had in psychosocial needs in a post-pandemic world, as you've said. I'll go to Justina. Do you have any comments or questions about this question before we move into what folks are sharing in the chat box?
Not that I can think of. I've never been in a chat that's so active. I really like it. So I would be happy to look over at the chat to see if there's anything else, Haley.
Yeah, sure. Let's take a look at the chat, and I completely agree. Folks are their questions are speeding by me, so I apologize again if we do miss anything. Some early comments in the chat box from Isabel Jordan about equity, including the intersection of disability and chronic illness and poverty. This too often gets left out of the equation, and completely agree, Isabel, and seeing some support for that and some agreement with that question throughout the chat box. And another comment from Claudia, just back to our earlier conversation about compensation. Compensation is tricky. Partners on sick leave may be offended if receiving compensation, and I suggest providing several options for recognition. Completely agree, Claudia, something that should be centered on what's salient and meaningful to a person. A comment from Tracy about we have had real problems in COVID to ensure equitable access to everything from housing to food security. We've had amazing collaboration of health, city, and many non-for-profits that came together to ensure people could access what they needed. However, this is going to go on a long time, and the most practical things like access to public washrooms is a huge issue for those without homes. I think a lot of advocacy will be required to build such services. I completely agree, Tracy, and I think that there's a lot to be said there about the coming together of different sectors in this time. And I think Justina's looking to comment again, so I'll go back over to you, Justina.
I really like the way that I believe it is Amy, who sits in the Family Advisory Forum, that says you can never go wrong if you start with the most marginalized groups. And I find that I always say that, and I bring it up in meetings when it comes to patient partnering. It's like, okay, and specifically like highlighting homelessness and even prison populations. I spent 2 months working at the prison in Northern Ontario as a medical student, and really it was the first time I was ever opened up to this patient population and realizing how vulnerable they are and things like that. So I'm curious as to, like, especially with the current political climate, what what are some steps that we could prioritize in the most culturally respective way these marginalized populations that don't often get their voice heard at the table?
Great comment and question, Justina. I will pause, and Faria, Christy, or Lori, anything you would want to add to some of the discussion that you've heard so far about this question? We do have a few more comments and questions that are coming in, but I'll give you folks the opportunity to jump back in if there's anything else you'd like to share or add.
Well, I'll take a stab at it. I think one of the things that we're doing as part of our new strategic plan, part of my role is to develop a strategic partnership framework, which would really allow for there to be partnership across different organizations in Scarborough to get a real holistic perspective and understanding of the lived experiences of a variety of different patient populations, whether it be Indigenous folk, those that have been incarcerated, those in the education system that might be slipping through the cracks, and really thinking about healthcare outside of the walls of our hospital building, and really thinking differently about community and community health and community care and the people that live in the community of Scarborough and beyond. So that is still underway and in progress, but I do think that that might respond a little bit to the question that you posed around sort of an action item for how do you get the most marginalized voices to the table. Sometimes it's not going to come in the form of, you have a committee meeting at, 4 o'clock on a Tuesday afternoon with some leaders and patient family advisors sitting around a very traditional looking table. And it might be very different. There's many times where I'm sitting in shelters or at the food bank, having conversations with those in the lobby where we're able then to bring back those voices and to allow for it to inform policy and things like that.
Mm-hmm. Yeah, and I really found that interesting when you were talking about not just having that traditional boardroom 4 p.m. meeting. For youth, I remember having engagement meetings in the middle of a school day or not being able to take the bus to get to the hospital, things like that. And even Lisa has put in a comment here about accessibility to webinars like this to deaf individuals or those who require interpretation. What are some other flexible options that you're providing within your organization to have for engagement opportunities with people who might need these kind of different accommodations, whether it's evening meetings or one-on-one, texting? I know if I was talking about texting her patients. Any other things that come to mind in terms of helping with the equity?
Well, again, another tangible example that we do at Scarborough Health Network is that we try to deliver all of our engagement activities and conversations at about a grade 6 level. And so when we're thinking about reviewing, materials or education materials or conversations, we have to make sure that we're bringing it to a level that, Lori has acknowledged herself as a layperson, that individual will be able to participate to the fullest degree or to the degree that they wish. So removing acronyms, ensuring that if there's some context that patient family advisor would require in order to fully participate, that someone's giving them a call and providing that context. When we go to the Patient Family Advisory Council, I team up with the different leaders across the organization. So for example, we just launched a brand new Stroke Center of Excellence. I work with those leaders to understand what is their end goal, but in fact my team creates the actual engagement activity. At our upcoming PFAC meeting next week, we're going to be having a dialogue around anti-Black racism and perhaps some of the lived experiences of those on our PFAC and in our community in terms of how they've accessed and perhaps either have been impacted or have witnessed racism at our hospital. So the individual that asked to have that on the agenda is our Vice President of People and Transformation. However, she won't be creating the actual dialogue. It'll be myself and our team that will create, ensuring that we're making sure that we're sticking to health literacy principles, making sure that the engagement activity is at the level that individuals would be able to understand. And for those that I know that are a part of our team that sometimes require just a little bit of extra attention, I call those individuals beforehand to give them the heads up on what we're doing as a few different ways that we try to promote inclusion at our hospital.
Thanks, Christy, and then thank you all for sharing. And Justina, I think there's a lot for us to think about, and Lisa, that was a great comment about, what are the different ways that we can provide access and equity, and I think it goes back to a comment that Amy made earlier in the chat about, needing to build a new table that allows full participation of people with disabilities to co-design in any emergency planning, whether medical or natural disasters, for evacuation and shelter-in-place needs. And I think COVID-19 in particular has given us a lot to think about in terms of how we are engaging and what we can do differently, what we can do better, and how we can improve moving forward in our engagement to make things more equitable and accessible. I think I will move us on to our next question, our next formal discussion question. So again, apologies if we didn't get to your question. We will make sure to share them all with the presenters afterwards and get any additional information back to folks. Our next question again is really, we've explored some of this, and so we might not have to spend too much time here, but wondering what barriers to diversity and equity and engagement have been exacerbated by COVID-19, and how have you overcome these barriers? So Faria, Christy, and Lori, is there anything additional you would want to share in this question or anything you would specifically want to highlight? I'll go to you first, Faria.
I guess, yeah, it was kind of already mentioned, but just, youth not having access to reliable internet connections and services and things like that. So that's one barrier for sure. Another that we noticed is, although we're hosting things from home, home might not be the safest place for a young person to have these discussions, to talk openly. There might be, either they're not comfortable, there might be some issues of domestic violence or something, that doesn't allow them to have that as a safe space. So that's definitely a huge barrier, especially because of COVID. Youth can't go to their counselor anymore in person to meet with them, and just not having that protected conversation over the phone. So, we're trying to develop and work with the youth to find what would be something like an alternative way for them to feel more comfortable to have those conversations and to re-engage them. But that's definitely something that we're facing right now as a big difficulty, but yeah, we're trying to see if there's other ways, and so that's where we had our counselor come in, our psychosocial help, to help us brainstorm and see what other avenues are there to address this issue.
Thanks, Faria. I think that's a great point, and I know, Justina, you've made a comment about that in the chat box. Really recognizing and being aware that home is not the safest for everyone, and especially youth, and certainly something to consider. Isabel Jordan has also made a comment about the key to engaging with new groups is relationship buildings, and that she's a big fan of physically going to where people are, breaking bread, having coffee, and going to where they are comfortable, and that's just not possible now. So really appreciate what you've shared, Faria, about bringing in psychosocial supports to explore what a new comfortable might look like in this time. Christy and Lori, any thoughts or anything else you'd want to add to this question?
I think not as it pertains to our partnership particularly, but I have heard from a clinical point of view the amount of isolation that our community is experiencing by not being able to get out and to connect. When we think about community health centers that are notorious for organizing wonderful things like knitting clubs, book clubs, things like that bring community together, that's a real challenge. And when you think about patient partnerships, you think about the beautiful collaboration that we create, which can be challenging for some to do this virtually. And I imagine that even doing conversations like this can be really challenging for some to hold their attention, to be able to truly share their authentic selves, things like that. I think from a practical point of view, onboarding and recruiting. We know that COVID has exposed many of the vulnerabilities that exist, and of course those are the very individuals that we want to better understand and partner with. But our recruiting has sort of been placed on hold, not permanently and not formally, but as you can imagine, not a lot of folks are looking for this type of opportunity right now, as I think they're trying to sort of scrape by. So when I think about our patient partnership program, and I think sort of reflecting on that, we do routine, routine engagement around recruitment, and it's just we go out to different communities, but the communities aren't gathering right now, so it's very hard to have those types of conversations.
Mm-hmm. I think the one thing that I've missed, certainly, and I'm hopefully looking forward to, is there's a level of, it's impersonal to be on a Zoom meeting. And I guess because I have some time on the PSAC at Scarborough Health Network, I've developed wonderful, warm relationships with people. And I may not see them but month to month. But those relationships aren't as nurtured when you're not seeing people, when you're just a face on a screen. And I think that our contributions will increase either when we become comfortable with the technology and how to interact, or when we can resume, hopefully, some kind of in-person activities.
Thanks, Lori and Christy. And Faria, I see another comment in the chat box from Tracy, and this echoes what Tracy had shared earlier, saying, I think the only way to address barriers in situations is to have very strong collaboration among as many community agencies as possible, that this will be very difficult to address barriers if we have a second wave and it's cold outside. And I completely agree, and I think this is something we're hearing from folks consistently. And I know, Christy, you had shared earlier a bit about kind of that focus back to community, and I think that's so important, and where we're hearing those pockets of greatness and goodness in this space is really that community connection where we can think outside. And as Isabel said, you know, what is the option to kind of build these relationships in that same comfortable way, and how do we create that community sharing, relationship building space virtually with people who have been othered? That's something that we're hearing a lot, and I think this conversation is a great starting point for us to continue to share our ideas. I'll pause and go to Justina to address some of our additional comments.
Yeah, I think I want to address what Bob Strain is saying from Fraser Health about rural locations having no transportation to sites and things like that. So one of the things that's been further exacerbated by COVID, and I'm experiencing here in Yellowknife, is we were already, I've already been isolated in the north prior to a pandemic, and then add a pandemic into the mix, and now we're looking at even further isolation. So it's very, very difficult. In rural communities here, I rely on being able to go to my neighbor's house, being able to go to my friend's house, and that physical interaction, being able to see patients and loved ones in the hospital, that goes just beyond rural communities. All this isolation, I think as a patient I already felt isolated in general, and then adding all these different factors at play. During my 2 weeks of isolation here, my patient partnering organizations actually checked in with me more over the phone because they knew that I was in a rural community. So if you, I think it's even best to even engage more with patients at this time, check in more informally over the phone or over text, because we might be needing it more than thinking of just giving us our space. So that's just some food for thought there.
Thanks, Justina. There's a really great comment from Amy, the Family Advisor Forum, saying, you know, we must keep in mind that some ethnic communities are very engaged amongst themselves, whether via WhatsApp or other means. We need to take the time to get to know these communities given the current constraints, and I think that's a great reminder and a really great point. It goes back to those foundational elements of engagement, of taking relationship building at the beginning and taking the time to do that and meeting folks in a way that works for them, and a really great point to remember that folks are very engaged amongst themselves, and how are we taking the time to get to know them. I've seen a question that's popped up a couple times, just wondering if there is a diversity and cultural sensitivity specialist at your organizations. And Christy, Lori, or Faria, is that a role that has been built into Alberta Health Services or the Scarborough Health Network?
Yes, at Scarborough Health Network, there is a diversity and inclusion specialist, and actually, if anybody's interested, there is a brand new posting that is up on LinkedIn right now, looking for a diversity and inclusion specialist. So yes, we do have one, and it's, again, a part of our strategic plan to become a much more inclusive organization.
Yeah, same with Alberta Health Services, they have that as well. And then with the projects that I work directly with, like we do have partnerships directly with Indigenous Health. So we have been working closely with them to have that inclusion and representation in our projects as well.
Thanks for addressing that. A few comments from Esha as well, just about in evaluating and making sure that we are looking from a systemic perspective about whether our programs are relevant to communities, and that this must be evaluated. And I think that that's a really important point. Esha, you know, are the things that we're building and the programs that we're running relevant to the folks who are accessing them, and how are we doing that in real time during COVID? I'm not sure, Christy or Faria or Lori, if there's any comments about ways that you've checked in with folks to make sure that programming is still working for them and is salient to them.
Yeah,
So
like I mentioned. Oh, sorry, go ahead.
No, please go ahead.
No, I was just saying, so yeah, for like I mentioned a few times, like with our projects, we do have that Indigenous perspective. We have Indigenous youth that are coming in and helping us, make sure that we meet cultural competencies. And then within our council, we also have diversity, and one of the work or pieces that we're working on right now is a recruitment flyer and a recruitment video. And so in that, the youth want to show their faces. They want to show, their diversity and their background, so that if another young person were to see this flyer or this video, that they would see themselves represented and they'd be more inclined to join. So those are some ways that we're trying to include that diversity and cultural sensitivity.
Thanks. And another question that's come in from Donna about what mechanisms do your organizations have for patients to safely share concerns about their experience? We'll go to you first, Christy and Lori, and then to Faria.
Okay. Well, our patient family advisors can certainly share their concerns with myself or anybody else as a part of the team, or absolutely with our patient relations department that responds very eloquently to the concerns of our patient family advisors, as well as those that have had care delivered at our hospital that require further conversation.
Thanks, Christy.
Yeah,
Faria?
Yeah, so we have check-ins, and either the youth can come to me specifically, or either one of my colleagues as well. But we try to have that open transparency in our conversations, and give them that space that, hey, if you don't want to talk about this, that's fine. If you do, let us know. And then, like I mentioned earlier too, we have access to our psychosocial supports as well, so that we're kind of, then it's, I guess, a different person. Like, it's not directly someone from our department, it's more of an outside person, so in case they have any issues with us, with the staff, then they have someone else to go to and talk to about that. So just making sure that they have more options of who they talk to is important.
Thanks, Faria. We'll go over to Justina for the last comment on this question, and then we'll move to our third and final discussion question. So Justina, over to you.
Yeah, I've been loving this this chat going on. Amy's bringing up some really important points. So just to close off this discussion, I always like to highlight tokenism when we talk in patient partnership context. And I have found myself in situations where I was the token, or I felt like I was being in a situation of tokenism by being a patient partner, getting a seat at the table, being invited into the meeting, but really that was just it. It was just an invite. It wasn't really fully feeling like I was engaged. So as we start talking about diversity and equity, and we can't just be giving someone a role but not providing them with the supports in place and that full engagement to really feel like they're not just I think another fancy silo is how Amy described it. So let's just always keep that in mind as we're calling for an increase in diversity and increasing that to avoid tokenism. So we'll go into our last question here now, Haley.
Thanks, Justina. So we'll move over to our third and final question. I have written here that we're 3 months into COVID-19, but I think I might have underestimated that. We might be at about 4 months now. So really wondering what successes and what issues surrounding equity and access to engagement are you seeing across the country and within your organizations? And I think we've heard a lot about some of the issues folks have encountered and are still encountering. So we'll welcome our presenters and then all folks to chat in about successes, if there's any of those pockets of goodness and greatness that folks want to share, and continue to share any issues that are still occurring in this space. So why don't we go to you first, Faria, to share about any successes or issues.
Mm-hmm. So for successes, I think just the biggest thing is having our youth still really engaged with us, whether it's from the council or with our ITT project, and giving them the opportunity to share their experience, especially with the COVID consultations that we hosted for them. We got a great number of youth that were engaged in that conversation, and just I think the success of it was that first we got to listen firsthand to what their experiences were, but also what came out of it was these two engagement pieces with social media campaigns that were developed and that are still being worked on. So it was nice to see a direct outcome and a very quick outcome, because with this pandemic, it's very time sensitive. You don't have months and years time to develop any of these resources. You need to act fast. So it's just nice that we were able to see something come out of it so quickly, as well as organizing a webinar for youth allies, having that come out right away, and just to share the stats and share things of how COVID has been impacting youth, especially when it comes to substance use and mental health. I think also, again, with our ongoing work, with our other projects, like our resource development with the ITT, being able to have youth come every single week with us to meet with us and discuss things. And just, I guess, the biggest success for me, I think personally, is just the feedback I receive from the youth, that they're really thankful and they're really happy to be a part of something, that they feel like their life right now has some more purpose with sharing their lived experience, and having that feeling of being valued is really, really essential. So I think that's been a great success for us for sure. I'll turn it over to Christy.
I'll respond perhaps at a very high level. I think that there is differences that exist in terms of engagement and degree and level of engagement of patient-family advisors, patient partnerships across organizations. And I think it'll be something that even for ourselves on this call to think about, where are you excelling or making a difference, and where are there opportunities to strengthen. And so today we spoke a lot about our Health Equity Certificate Program and the great contributions that we have been making in that particular area, but also be very vulnerable to share with you that we have not partnered greatly with our patient-family advisors on our family presence policy and our response to no visitors, and what that shift needs to look like post-pandemic. And that's an area that we continue to raise advocacy around, that gap that there currently isn't, and there probably should have, missed opportunity to be engaging more highly and effectively with our patient partners and better understanding what the experiences are of them when not able to come through the doors as they had in the past. And I think that probably exists for all organizations, that there's pockets where we're able to do really, really well, and then of course that there's those pockets where we continue to look for those opportunities and to strengthen our efforts.
Thanks, Christy. Lori, did you have any thoughts on that question?
No, Christy covered it beautifully.
Great. Thank you all. And seeing some things come into the chat box, did you have a first question for you, Christy? Did your OHT engage with PAC for pandemic planning and assessment centers?
I'm going to actually ask Lori to respond to that question, because Lori is one of 2 or 3 patient-family advisors that sits on our Ontario Health team for Scarborough.
To the best of I personally wasn't involved. I'm not aware of a call-out for PFAs, but it could have happened without me knowing.
And that's a great lesson learned right there, right? So if your patient-family advisor that is on the Ontario Health team isn't aware if there's been engagement, that's a wonderful dialogue and conversation to raise visibility around that. So great work, yeah.
Thank you both. Lots of comments coming in. Amy sharing that given the recent death of George Floyd and the demonstrations occurring worldwide, that their hospital board will hold a meeting next week to see what actions can be put in place. The subject being implanting equity, diversity, and inclusion, and sharing that there is some skepticism, but at least making it onto the hospital board agenda is a start, and that they recognize that words are not enough, which is followed up by Justina's comment about being tired of reading statements from institutions and would love to see real action. Not sure if you want to elaborate on that at all, Justina?
No, I think it's just as simple as that.
Yeah, great. Thank you, Justina. And I see, Anne, I've seen a couple comments from you about the hot topic you're hearing most about right now is family presence policies in healthcare facilities. And loved ones being categorized as visitors with little or less influence in patient care in institutions. And I know you spoke about that and addressed that, Christy. I'm gesturing like you're sitting beside me, but it's just to your webcam. And that's something that we're exploring right now at CFHI in our Better Together work, is really what the shifts have been in family presence due to COVID-19. And really, I think kind of the steps back that we've taken, and I think we've heard from a lot of folks that felt that family presence was a little bit more firmly embedded than it is. So a lot of work to be done, and a lot of things we could be doing in that space. In particular, CFHI did just release a considerations document about the reintegration of family members as partners in care. So I invite you to check that out, Anne, and happy to share that in the chat box with everyone. Looking to see if there are any other comments from folks. Bob Strain at Fraser Health, that BC has 1 to 2 organizations that display opportunities to participate in COVID-related research. I love participating in RACE DC. The surveys they produce are most thorough and deal with equity issues as a part of their questionnaires. That's great to hear. That's great to hear, Bob. Happy to hear that that's an opportunity for you to participate in the COVID-related research. Just looking to see if there's any other comments or questions here from folks. Is a comment from Isabel Jordan about feeling conflicted about this question, and you know, I see people who most need to be engaged in the most urgent areas being left behind this. And I completely agree, Isabel. I think this is a conversation that we've been circling around for a bit and asking that hopeful question about those pockets of success and where we need to go. I think there's a lot of work that still needs to be done in this space. And I'm really thankful for all the folks who've given energy and time to having this thoughtful conversation in our chat box and amongst themselves. Any other thoughts from Justina, from Christy, Faria, or Lori?
I think it's important to highlight this considerations document that's being put in, and I've been sharing it. I've been working with the territorial government here. I shared it with our manager of caregivers and services just yesterday, and because we've been having a lot of family members being impacted with not being able to visit their loved ones. So welcoming back caregivers during COVID-19, great document by CFHI. So there's a link that just got posted there.
Thanks, Justina, and thanks to the folks, Jesse, who are sharing it in the chat box. I see that there's another comment from Esha, just about within the context of the COVID-19 pandemic, access to policies and programs that value typical constraints of patients as individuals to get affordable masks, availability of hand sanitizers, and opportunity for home-based consultations for social distancing would help. Completely agree that access to those items would be really, really crucial. Hearing from Valentina, the voice of patients, families, and caregivers were able to be heard. And the SLT, I'm not sure what that, took the time and debriefed with the advisors and are taking actions to consistently engage patient and family caregivers in decisions in the time of crises and beyond. Thank you for sharing that, Valentina. A nice positive one of those successes that we're seeing. And a question from Cyril. If it's relevant to the subject, do you think any laws should be modified or put in place regarding the pandemic? I think that's a really interesting question, and we've heard from, and I'm not sure if you mean in particular reference to healthcare, but we have heard from folks who have presented previously in our Spotlight series, our webinar that we held 2 weeks ago with folks from the Saskatchewan Health Authority and Hotel du Grace in Windsor. We're speaking specifically about how they have actually modified their pandemic and emergency response processes so that now going forward, none of those responses or processes will occur without proper engagement. So it's written physically in the policy of their organization. So I'm not sure if that's what you meant by your question. Any other comments or thoughts from anyone on the line? I see some folks are still chatting in, and again, if we missed your question, I apologize, but I'll give any last words to our presenters or Justina before we move into our closing of the webinar. Anyone else want to share anything? Hearing silence from folks, Then I see there's one final parting thought from Amy, so I'll share that before closing us off about we have seen in many cities across Canada that COVID-19 disproportionately hits certain race groups, and many have come outrightly to say that racism is a public health concern. Will this translate into accreditation bodies requiring that concrete action be taken to correct this looming public health issue? Any QI projects that will look at social justice, especially to address those living at the intersection of race and disability? I think that's a fantastic question, and Amy, and really somewhere that we should be turning our eye with programming, with accreditation, and really happy to hear, as you said earlier, that your hospital board is meeting about that, and would love to hear what comes from that, and hope there's more than words behind that. So I will move us in to our closing, and so I just want to say thank you so much. Thank you, Justina, for hosting the webinar and for facilitating with me. Thank you, Christy and Lori and Faria, for your presentations. To our amazing webinar team, Sheena, Kelly, Mihaela, Isabel, for making sure everything went off without a hitch, and to Jesse for monitoring the chat box. Thank you, everyone, for your insights and your thoughtful commentary and ideas, and for coming to this space with your energy and your intention, and I really appreciate the discussion that we had today. Thank you all so much. We will close out with our typical CQI poll. Your feedback is invaluable to us for future webinar design, so that we ask if you can just please take a moment now to provide some feedback on today's session. Thank you so much, everyone, and thank you again.